So we have a very good session lined up today. We have talks besides myself by Dr. Santosh Bhide on perfect surgery. Dr. Piyush Kapoor is going to talk on tackling the astigmatism part. Dr. Neeraj will cover achieving 20 by 20 with PCR. And Dr. Anand Parthasati is going to tackle phaco in post-keratorefractive surgery eyes. Dr. Sheetal will cover optimizing results in pediatric cataract surgery. Dr. Nivyan on choosing the right IOL. Dr. Parul Sharma will cover optimizing toric IOL accuracy. Dr. Sachin will cover cataract surgery in post-retinal surgery eyes. And that will be the last talk will be by Dr. Vanashri, and she's going to tackle refractive surprises post-cataract surgeries. So we begin the session, and I'm going to cover perfect biometry. Can we better it? We all know that cataract surgery is now a refractive surgery, and in earlier times, cataract was removed first and spectacle prescription given last. But today we calculate power of IOL first, and cataract surgery is done afterwards. So IOL calculation plays a very important role to determine refractive outcome after the cataract surgery. Earlier times, since IOL power has been calculated basically using two parameters. One is
Slides are not coming.
slides are not coming here. So since 75, IOL power has been calculated using basically two parameters, that is keratometry and axial length. But now and today we can customize the power of IOL to achieve near plano results even in highly myopic or hyperopic eyes. And there are a group of patients who greatly value their emetropia. And when you break news to them that they require spectacles after the cataract surgery, they are extremely disappointed. So what are the major sources of prediction error for IOL power calculation? ELP prediction accounts for the major part, that is 35%, followed by axial length 17% and keratometry 10%. Few subjects in the field of ophthalmology are as complex as IOL power formulas because it involves the use help of mathematicians, and we ophthalmologists by nature are not very fond of mathematics. Earlier formulas had some assumptions. That is, there was fixed ratio of anterior corneal curvature and posterior corneal curvature. Cornea was treated as a thin lens with a refractive index of 1.33, and this used to give us correct result in average eyes, but not in atypical eyes. And there were some other hurdles in accurate estimation because there were some more assumptions. It was assumed that shorter eyes and flatter K eyes will have shallow AC and shorter effective lens position, in contrast to longer eyes and steeper K eyes, which are supposed to have deeper anterior chamber and longer effective lens position. But Holiday told us that there are 9 types of eyes. Even in eyes with normal anterior segment, 80% may have short and 90% may have long eyes. And in eyes with normal axial length, 2% may have shorter or longer anterior segment size. So relationship between the anterior segment and axial length is not proportionate in 80% of short and 90% of longer eyes. So older formulae are bound to fall in short and long eyes. So is it bad to keep using the older formulas? Yes, because with that only 1% of the surgeons achieved accuracy more than 92% with plus minus 0.5 diopters. And this was renal medal lecture which was given in 2016, which told us that if we change with times, we can have 91% of eyes within plus minus 0.5 diopter of the target refraction. So what are these newer formulas? I'll just going to enumerate the basic features of these newer formulas like Hoffer H5, Lada's, Olsen, Barrett, and Hill RBF calculator. Prediction theory says more the number of variables to describe an event, more accurately the outcome can be predicted. So we have moved on from 2 parameters in 1988 to 4 variables in Olsen, 5 in Barrett Universal 2, and 7 variables in Holiday 2. Artificial intelligence is utilized in Hill RBF and ray tracing in Oculus and phaco optics. And there are some variables which are intermediate factors which help us to arrive at effective lens position. SRKT while had A constant, Haigis had A0, A1, A2, Hoffer Q and Holiday 2 have anterior chamber depth, and Holiday 1 has surgeon factor, Olsen has C constant, and Barrett has lens factor. So what are these lens constants? They were actually developed during the later stages of regulatory processes and with limited number of cases when plano convex lenses were used and convex ultrasound biometry was used. But with this, we used to have some error. So it makes sense to optimize the lens constant. Either you can analyze your own data, or you can use software like www.drhill.com or Dr. Hagee's ULIP website. Surgeon who does not personalize his constants will constantly have some refractive surprises. This slide on the left shows that within zero point 0.5 diopter, without optimizing, if you had 18% success rate, this can move to 70%, and within 1 diopter you can move from 50% to 95%, as shown on the pink bars in the right side of the slide. So what is this new formula? Barrett Universal 2 is recommended now for all types of eyes, whether short or long eyes. Hill RBF uses artificial intelligence and pattern recognition, and the predicted accuracy of 91% of eyes within zero point 0.5 diopters. Olsen formula uses ray tracing. Lada super formula intelligently combines the best performing portions of multiple third and fourth generation formulas. Kane formula uses, besides axial length keratometry, anterior chamber depth, also lens thickness, central corneal thickness, and gender of the patient to make its predictions. EVO 2.0 formula is based on theory of emetropia, and it's a thick lens vergence formula. Intraoperative aberrometry is best valuable as a confirmatory or complementary test. It is not going to make lens calculations obsolete in near future, and the only indications are in post-refractive surgery cases and in astigmatism correction. Ray tracing IOL calculation is almost equivalent to third generation formulas in normal eyes, but it is superior in odd eyes with extreme axial length or with the different corneal condition like post-keratorefractive eyes. But there are limitations of ray tracing formula, and because it still depends on the accurate estimation of the effective lens position, so there is no reason to switch to ray tracing formulas. Hill RBF formula not only gives us IOL power, it also tells us the accuracy level, whether it is inbound or out of bound. That means whether your patient data parallels the data in the database of the this Hill RBF, that means it is inbound, otherwise it is indicated as out of bound by red dots. If we compare Barrett and Hill RBF, both are good choices. They are current, they are more sophisticated, and although they use completely different premises, like Barrett uses the artificial intelligence, Hill RBF uses artificial intelligence, and Barrett uses paraxial ray tracing formula, but both these methods surprisingly give recommendations that are within 0.25 diopters of each other. So what should I do? Should I use multiple formulas and compare or average the results? Douglas Koch follows this policy, but Holliday and Barrett says horses for courses, that is specific formulas for specific condition. So what is the best way to deal with eyes? We always used to say Hoffer Q, but the conventional wisdom has been replaced by the latest literature, and they say either use median of Holliday 1, Holliday 2, or use just Barrett and Hill RBF. And the problem in longer eyes is that we get hyperopic surprises, particularly when we are dealing with eyes more than 24 millimeter. And what are the three formulas which work well? These are the ones: Barrett Universal 2, again Hill RBF, and these are the newer formulas which are available on site. You don't have to pay anything. Barrett, Hill RBF, Olsen, Kane, EVO, Pearl DGS, all these formulas are available online. And this was meta-analysis which was published in Journal of Cataract and Refractive Surgery, and which they have compared all these formulas in shorter axial length, medium axial length between 22 to 26, and longer axial length more than 26. And you will find that the formulas which are best performing are Kane, followed by EVO, followed by VRF, Barrett Universal 2, Hill RBF, Pearl DGS, VRF. SRKT is not there in the first 5 or 6 best performing formulas. This was other meta-analysis which was published by Meles in 2019, and it also gives us almost similar results. So what are the steps you can take to maximize the likelihood of getting better outcomes? Please optimize your constants, validate your measurements if your readings are outside the average, that is axial length less than 22 or more than 25, keratometry is less than 40 or more than 47. Take the measurements yourself, because ophthalmologist is the most knowledgeable part of the team. So don't remove yourself from the process. Spend extra time counseling the patients with short eyes or previous refractive surgery, and don't just keep doing what you have always done. because then you will get the same error which you have always got. And but we are still stuck at 90% accuracy within 0.5 diopters. Limit is now not the formula, limit is the least count, that is the precision of the measurements which are put into these formulas. And the precision limit for keratometry is 0.25 diopter. For axial length and anterior chamber depth, it is 0.1 to 0.2 millimeter. So these error limits keep us at 90% accuracy within plus minus 0.5 diopters. And again, there are some measurement errors in the IOL manufacturing tolerance given by ISO. Imagine that you have calculated the power of your patient to be 21.3 diopter, but the nearest power available is 21.5 diopter, and you will find from this chart that the error permitted is 0.4. So even if you have done correct estimation, good accuracy, good formula, good surgery, still you will have error of 0.6 diopter, that is not within your control. So has the stage come where we can use single formula for all eyes? I think it is difficult to say, but the formula which comes closest to that accuracy is the one, Barrett Universal 2. This is the chart which shows that these are the various formulas which fit into the various axial length less than 22, 22 to 26, and more than 26 millimeter. So improvements in technology have allowed accuracy of biometry to double every 5 to 10 years. So previously 80% accuracy was acceptable, but now 90% is achievable. So we should always strive for what is achievable and not settle for what is acceptable. Smartness is learning from not only your own but also from others' mistakes. So let us not only become experienced but also smart. And now we are on the verge of level of accuracy for refractive outcomes never before seen in the field of ophthalmology. But to fully enjoy this, use validated measurements, optimize your lens constants, and adapt to newer technologies. And we are thankful to all these ladies and gentlemen for bringing us to this level of accuracy: Holiday, Wang, Koch, Warren Hill, Thomas Olsen, and Barrett. Thank you everyone for your kind and patient hearing. And with this, I always also extend invitation to all of you to please come and attend DOS midterm conference, which we are organizing in New Delhi from 2nd to 3rd September. Thank you. Now I'll ask the next speaker to please come.
By Dr. Bhalla. So now I invite Dr. Santosh Bhinde for his next talk about perfect surgery. Next. Then I begin. Maybe you can just.
So now Dr. Piyush Kapoor will give the talk on tackling the astigmatism and reshaping the cornea where we are off target. Dr. Piyush Kapoor is a renowned cataract and refractive surgeon from New Delhi, and he is a prolific cataract surgeon and a very good academician. Dr. Piyush Kapoor, please.
Thank you, Dr. Bhalla, for your kind introduction and giving me this opportunity. In my talk today about the precision in cataract surgery and trying to reach 2020, I'll be talking about astigmatism and how do we manage it. Well, first of all, I would like to specify that we should always target and treat any astigmatism more than about a 1 diopter, or rather now the precision is reaching up to about anything more than about a 0.75. For which we need a right clinical estimation of astigmatism. We need to review which lens would be the best for our patient, and also we can reshape our cornea without using a toric IOL. The main backbone of a treatment of astigmatism lies in the proper evaluation and the right estimation of the astigmatism. Mostly, my talk would be restricted to treating the regular astigmatism because they have the most predictable results, and we are rather not bang on, or we still cannot very well manage the irregular astigmatisms. So in this, we have the whole plethora of instruments available with us, like the keratometry, the autokeratometers, the Placido disc based, and the pentacam. The main important pearl is that either we take multiple readings on different occasions or we use the same instrument on different occasions. Like depending upon the availability, what we have with us, we can either take multiple readings on different instruments and make an average out of it, Or if we have limited resource, we can take different readings on different occasions and actually be more sure of what we are dealing with. The K readings generally should not vary anything more than about a zero point 0.5 diopters. And when we consider the axis, the variation should not be more than about 10 degrees. If we are beyond the scope, then there is something to be dealt with. The more accurate reading can be attained by tomography with the LED based light source, which can actually give the best possible posterior estimation of the astigmatism. And while dealing with astigmatism, now is the era that we deal with the total corneal astigmatism rather than just talking about the anterior or the posterior separately. And this is very well based on the corneal index, which has been specified in Dr. Bhalla's talk also, that we need to be specific that what refractive index of cornea we are taking, because this can also change our biometry or the alignment of the lens. It's very important that we need to have the right calculation of the posterior corneal astigmatism, which was not talked in the past, but in the present days, it is a must while treating astigmatism. As we know, most of the corneas have a little plus bar in the posterior part when we are talking about the horizontal meridian. As a result of which, we generally tend to overcorrect with the rule astigmatism, and we can always undercorrect and against the rule astigmatism if we do not estimate our posterior corneal astigmatism. So newer generation instruments like the Antrion, the IOL Master 700 give us an insight into the total estimation of the corneal astigmatism. They give us the total K values, which is the way of calculating astigmatism on date. It can actually give us the right desired readings, and we can select our individual template. We can use the correct formulas which we need, like the Barrett suits and all, and get the proper biometry readings. So once we are done away with the proper calculation, we go on to the online calculators which are available, or we can use our instrument per se to calculate the alignment of the lens which we need to place. I generally in my practice use both the methods. I use my lens star, I use my Antrion, and I also ask the company people whichever lens I am going to implant to give me the sheet, and I take an average out of it to just see that whether my accuracy is actually appropriate or not. Ever if I have to err towards one side, I generally always go with the one calculated sheet which is given to me by the company guys, because I have seen that they have optimized according to their lens, and they actually are little more on the accuracy when we consider alignment of the lens. So having selected that where we are going to put the lens, it's very important to understand that which IOL design we need to use and which has got the best rotational stability. Like I have been using various lenses, but on date, the best choice with me is the Technistoric 2 platform, which actually has a kind of a better stability, because the edges of the lenses are just roughened up so that the rotation is minimal. And I have seen that with the newer Technistoric 2, almost we tend to get 100% result, and the rotation is very minimal in the post-operative course. So going on to the steps, how do we actually plan the surgery? I would say that first we do the toric marking. There is a small video which would demonstrate that how I in my clinic do the toric marking. We make the patient sit on the slit lamp, ask the patient to look absolutely straight by giving the distant target, and see the 180 marks on the cornea. Either I use a bubble marker or a single pin. Here, first I am using a bubble marker and getting the 180 and the 90 points aligned. And this is a single pin alignment where I just see the 90-degree mark and put it with the pin. Depending upon the patient cooperation, I generally select how to go about with it. Once having marked in the OPD, we take up the patient for the surgery, and on the desired axis, give the marks where the lens has to be aligned. I would not go on with the surgery because of paucity of time. Once the alignment has been done and a proper surgery has been done, the lens is placed on the desired axis. But sometimes these accuracies cannot be really attained. There is always a scope of error, and this was one of the case which I did, where the lens was actually present at almost a 90-degree rotation. And when I went back to saw the data of this patient, actually the optometrist who had calculated the K values and given for the for the toric alignment had just reversed the 180 and the 90, and we landed up having the patient being placed the lens accurately, but it was at a 90-degree misalignment. This was 2 weeks post-operatively, but we went and realigned the lens by just lifting the rexus margin a little, because the lens gets the capsule gets adhered to the margin of the lens, injecting a little viscoelastic in the bag to separate the lens from the capsular margins. It's very important to be patient in these realignments, because if you are a little too aggressive, you
Dr.
can
Piyush,
land up
can you
in
summarize?
tears.
Yeah.
Yeah, I'll just summarize, sir. Once we have realigned the lens, then I would just talk about how we can reshape the corneas when we have to deal with the astigmatism. And generally, I would say reshaping the cornea can be done for anything between 0.5 to 1.5. The incision can be aligned at the steep axis. For 0.22 incision, I generally give a SIA of 0.15 to 0.18, and when it is as big as a 0.55, it can actually treat up to about a 0.5 astigmatism. Whenever the astigmatism is anything more than a 0.75, we use the LRI. Here is an LRI which I had given with a flax for a patient which we implanted with a VVT lens. And whenever the astigmatism is less than a 0.95, I generally use a double CCI if the patient is not affording a flax. And if at all we are not able to reach bang on the target, we have bioptics with us, which is, I would say that the surgeon should never be very aggressive. And if we are very close to the target, I generally discourage any such thing. Thank you.
Yeah. Thank you, Dr. Piyush. That was indeed a wonderful talk. Now, can I invite Dr. Neeraj Manchanda? He is going to deliver talk on achieving 20 by 20 with the PCR. Dr. Neeraj Manchanda again comes from New Delhi, from Healing Touch Eye Center, and he's a great anterior segment and posterior segment surgeon. Dr. Neeraj Manchanda, please. Meanwhile, if you have any questions, you can please pass them on to me so that we can have the discussion at the end after the talks.
So can I start?
Yeah, please.
Good morning, everybody. It's a wonderful morning. The weather is perfect outside. And thanks for Dr. Bhalla for inviting me to this dais and speaking a few words about this problem, which is a very, very common problem, a posterior capsular rent, achieving 20/20. So what are the risk factors for a PCD? So basically it is poor visualization. There could be a corneal opacity. Initially we can always, somehow when you are starting a surgery, you can make out that this kind of cataract is going to create trouble. So these are some of the points that you should not miss during the clinical exam. A posterior polar cataract, which is very important, with the latest machineries and gadgets available like the anterior, which is available at the Healing Touch Eye Center. We can now even see whether the posterior capsule, the polar cataract is penetrating the posterior capsule, or whether the posterior capsule is still intact. So modern technology does help even more. It could be a post-traumatic cataract, a cataract with a small pupil, pupil not dilating. Make sure that you write on your file that this is a small pupil cataract. This is just an indication in the beginning, so that when you are starting to operate, your team is ready with pupil expanders or whatever you want to do. Then weekend zonule pseudo exfoliation and any vitrectomized eye. You have to be very careful. I also do posterior segment retina surgeries. So we have to be more careful with the patients that are operated vitrectomy. Small capsular access during the surgical, extended capsular access when you are operating, uncontrolled hydrodissection can lead to this problem. And then there could be a surge in the machine could be faulty, or maybe you are not operating properly, running after small pieces, and improper IOL insertion. These are certain predisposing factors. When you're operating, you should try to avoid these things which I have written here. So what are the signs of catastrophe? That something has happened, maybe a rent or maybe the nucleus is going to drop. There is a sudden deepening of the chamber. You must stop there. Inability to rotate the nucleus, dipping of one pole of the nucleus, or there is an altered reflex in the periphery. So these are some of the things that you can make out that something is wrong is going to happen. What an anterior segment surgeon can do. A PCT or zonular dialysis can take place at any stage, might be any stage and any time of your career. It is not that I am operating for last now 25 years. Still, once in a while, something happens, and it is how you manage it that is more important rather than why it has happened or how it has happened. The management, the correct management is the answer. And don't panic, face it with a cool head. PCT does not always necessarily mean that there is a vitreous loss. It could be a small tear, and if you manage it well, you can do wonders. Everything is as normal as before. So how to avoid vitreous loss? Maintain the anterior chamber, use viscoelastic liberally, use of viscoat, dry aspiration, and in case of zonular dialysis, use endocapsular ring. So I'll show you a small video. So you can see here, this is a classical posterior polar cataract. We are doing the rhexis, a hydrodissection. This is a gentle, not dissection, only hydrodelineation in this case. You can see how I'm removing the nucleus, the epinucleus, and now you're going to see that sign here. See, this is where the capsule gives way. So after this happens, we are doing a dry aspiration, injected the viscoelastic. So I've cut short the video just to make it interesting. So you can see now we are trying to do a posterior rhexis so that I can implant a posterior capsule, a posterior lens in the back. So I am doing a posterior rhexis. I tried to complete the rhexis, but somehow it extended from there. But doesn't matter. You can still implant in lens. So I did this implant with the optic capture. So you can see did not go completely into the back, but the optic is in the back. You can see the capture lines. The optic is in the back, and the haptics are outside. So this is how you can proceed. So no vitreous loss. So if there is a vitreous in anterior chamber, that case there was no vitreous. Phaco aspiration should be avoided. Immediately withdraw the phaco probe, but maintaining the anterior chamber, clean the vitreous around the nucleus. A dry vitrectomy or a visco-assisted vitrectomy is the thing that is to be done. But what is not to do is, do not withdraw as soon as you see something wrong, do not immediately come out of the chamber. That can lead to loss of pressure in the eye and the vitreous can come out. Let it never collapse. With the other hand, you can inject the viscoelastic. So conventional methods are to be condemned. If you have all phaco machine these days have an anterior vitrectomy option, always be ready with it, especially the cutter should be ready. When in case of panic, most of the surgeons I have noticed that they don't have a cutter ready with them. Machine is ready, vitrectomy is ready, but cutter is not available. Always keep a cutter with you ready at hand. And automated vitrectomy is the choice of the present situation. What is the problem? The problem of automated vitrectomy is in our head. We have been doing a lot of courses in our hospital also, teaching people on model eyes about anterior vitrectomy. Don't be scared. It is a very simple procedure. Why I cannot do it? It is so easy that it is not difficult at all. These are the basic principles. Cut before aspirating, no pulling, no hydration, balanced fluid egress, and direction of the cutter should be anteriorly. And section and anterior chamber should be vitreous-free, and automated vitrectomy is the choice with a new cutter. Bimanual irrigation and cutting is preferred. Remove vitreous completely from AC and back and free the corneal and scleral wound. And again, free the pupil. That is the end point. Pupil should be freely mobile and constricting well at the end. So this is another video. This is a very old video. But again, these things don't happen so commonly and most of the time we are unable to record. So you can see here around a grade 2 to 3 cataract. Pupil is small. We were aware that something could happen. But what happened in this case again was not expected. We had almost finished the surgery, so you're seeing the hydrodissection being done. The nuclear pieces are being emulsified and aspirated. So epinucleus is left, and now you will see what is going to happen. Just have the concentration on the center part of the capsule. Accidentally, this is here the capsule is gone. So sometimes this can also happen. So this was luckily caught on the video. So these things can be avoided. So now we are doing a dry aspiration like I told you. And when the vitreous comes, this is dry, injecting the viscoelastic and doing a dry aspiration slowly. You have to be very calm, don't panic. That is the message. And whenever there is a slight vitreous coming out, you can use the anterior. See, this is the anterior vitrectomy cutter. Just to show, I have kept the cutter straight up. This is the direction the cutter should have. And then we can do a bimanual. We can go from one port, see bimanual. This is the irrigation and this is the cutter. So this is how the cutting should be done. Clear the free central area zone and remove the cortex. So what are more ticklish problems? So we initially discussed a PC rent without vitreous loss. Now we have discussed PC rent with little bit of vitreous, and now the most complicated part, PC rent with nucleus in the vitreous. Nucleus going in, the full nucleus going in, or pieces of the vitreous. So we don't have to run after. If the nucleus is going in, the best part is to let it go, let it drop. I am a retina surgeon also, so I know what to do. Even I don't go after the nucleus. I will do it maybe the next stage or same day if everything is available, my vitrectomy machine is ready, everything is okay, we can do at the same stage also. So, are you a qualified vitreous surgeon? Go ahead. If not, then call a vitreoretinal surgeon. There is no need to panic. A lot of studies have been done which show if you don't operate the same day, it is not going to create hell. It is going to be okay. Calm down the patient, tell them the truth. The truth has to be told to the patient that there was a problem, this has happened, and we'll take care of it. So that is very important. What you should not do is try to remove the pieces which have gone into the vitreous. Don't run after them, and never put a wire vectus in the vitreous. That can cause a lot of problem. So you can do it either on the same sitting if you have a qualified surgeon and the things are ready, or defer it next few days, calm down the patient, do his anti-inflammatory treatment, and then when the pressures are okay, you can do the thing. So your present imperfect handling of vitreous may make your future tense. This is a very important message. And what you can do is anterior vitrectomy, cortical cleaning, and PCIOL, if you are confident, you can put, or leave it for the vitreoretinal surgeon to do it if there are pieces in the vitreous. So this is another very old video, just to show you my last video, and half a minute to go. So you can see here the vitreous, already there is a rent, because this is a very old recording. You can see we are trying to do the dry aspiration with the help of cutter also, and removing the cortex. So what you can see is, you can see a big nuclear piece behind, and now see where it is going. It is going down, so let it go down. Don't run after it, and then you suture. This is my message. If it is going down, suture it and leave it for the vitreoretinal surgeon to do. So this is the message. Do not fish for the nucleus. Thorough anterior vitrectomy, remove cortex with dry aspiration, IOL insertion, only if you are confident, and refer to the vitreoretina surgeon. And last but not the least, tell the patient the truth. That is most important. In the era of medical legal cases, it is very important to disclose the truth. Anything can happen. The best of the pilots or best of the drivers can have an accident. So that is my message. Thank you very much. And thank you very much, sir, for inviting me again. That's it.
Thank you, Dr. Neeraj. I think there will be a lot of questions for you. Now, can I invite Dr. Sheetal? Dr. Sheetal is going to talk on optimizing results in pediatric cataract surgery. I think till the time Dr. Sheetal is fixing her presentation, Dr. Neeraj, do you use triamcinolone staining for vitrectomy, and for the benefit of delegates? What is the do you dilute
Definitely.
it?
I generally do not use triamcinolone because myself being a retina surgeon, I can clearly visualize. But if required, triamcinolone is one of the methods you can use to see that the vitreous anterior vitrectomy has been done completely. So that is the end point, just to check, like I told the few points, the pupil should well constrict, there should be no tags in the, and to see, visualize it better, triamcinolone definitely can be used, but I rarely use it. So I have not shown in my videos because I've never made a video like that, but it is a very helpful guide. But don't over inject the triamcinolone also, that is important. So it can be used.
And what is the dilution you use?
I don't generally dilute, we can do it full dilution. With the full, and we have to just, we can use the full concentration, and it has to be just put 1 or 2 drops, that's it. That is more than enough. Don't overfill it. Don't overfill it.
What do other panelists have to say? Do you dilute or you use same concentration?
We dilute actually.
How much dilute?
1:4 is what we dilute.
Okay, same.
Because dilution, if you are using the Tricot brand, but the Oro people are also making a brand which is for, so that we are using the Oro cot only. So that is the Oro brand I'm talking about.
Main thing is we have to do thorough vitrectomy and clear the section and anterior chamber of all strands of vitreous.
That is the most important.
Yeah. So now we have Dr. Sheetal.
Yeah, a very good morning to everyone, and thank you, Dr. Bhalla, for inviting me for this session. So, I'm going to talk about optimizing results in pediatric cataract surgery. So, we are going to cover all these headings, what is written over there. So, basically, we all know that cataract is a leading cause of childhood blindness, and there are various causes for it. There could be genetic, there could be metabolic, there could be some kind of an insult during the pregnancy because of the maternal infections, or there could be idiopathic later on in idiopathic, or there could be a trauma later on in life. So, for the management of congenital cataract or a pediatric cataract, there are some special considerations we need to take care of. Is these are anatomically young ocular tissues. There is a low corneal and scleral rigidity. There is a very elastic anterior lens capsule. There is a continuous ocular growth which is happening. There could be a lot of associated structural ocular as well as systemic anomalies, and a big issue is the amblyopia issue and its management. So pre-operative evaluation thorough needs to be done. So first of all, take the proper history, because you cannot evaluate every child for everything, and accordingly we can do things. The main 2-3 things which are similar for all the pediatric cataract surgery evaluation wise is the assessment of visual acuity. If a child who is very young and not having a central fixation, or a child having a nystagmus has a very poor visual prognosis, so you have to counsel parents that way, that maybe the visual prognosis is not very good. Do a proper thorough examination under anesthesia, do B scan to rule out the retinal pathologies, and whatever MRI CT scan required, if required, one can do it. Also other blood levels, if you are suspecting some metabolic causes, or so you're suspecting infections in the torch level. So timing of surgery, another thing which is very critical in pediatric surgery, is when do you do it. We all know that the critical period of eye development is 2 to 6 months of the age. For the unilateral cataract, it is a good idea to operate between 4 to 6 weeks of the age. Ideally, it is as soon as possible, but before 4 weeks, there are a lot of GA risk. And after 6 weeks, there are a lot of chances of amblyopia, so better to operate between 4 to 6 weeks. For bilateral cataract, again, it should be operated between 4 to 8 weeks of the age. Again, if it is a bilateral cataract, if there is not a high GA risk, you can do it 1 week apart, or if there is a high GA risk, you can do it simultaneously, but treat it as 2 different cases. Anesthesia, as we have discussed, and we know that GA is required, but one can give subtenance block, or I generally give peribulbar block to reduce the post-anesthesia discomfort. Now, the special considerations during surgeries, the surgery per se is not going to be different, because the nucleus is very, very soft, so you really do not require the phaco probe also. Most of the time, you can just do the lens aspiration with irrigation and aspiration. The most important thing in pediatric cataract is whether you're going to do the PCCC and whether you're going to do the anterior vitrectomy, whether you're going to implant an IOL. That is the thing which we are going to consider. So incision superior is preferable, because it's protected by lid whenever the child is playing, or if some trauma happens, it is always a good idea, but it's not a must. Whenever we are talking about anterior capsular management, use the trypan blue, because it will reduce your little bit of elasticity also, and it gives you definitely a better view. Now, the direction of forces are very, very important while doing CCC, unlike adult cataract, where if this is a CCC flap, what I have drawn, and if you do the tangential force, your rexus is going to go out. So what we generally do in pediatric cataract is, because it is very highly elastic, this thing, your force should be centripetal, so you have to actually pull the flap towards the center, so that you will get a desired amount of rexus. Always plan a smaller rexus than what you wanted, and you will get a desired one. The rexus can be also done with the vitrectomy cutter, or you can do it a femtoLASIK also. But a study which has analyzed the pediatric rexus on a porcine model, they found that the most regular and stable edge is with the manual rexus. For the posterior capsulotomy, again, a child less than 6 years of age, or child even if it is more than 6 years of age, who has nystagmus or some mental retardation or mentally subnormal, where the yak cap would be difficult later on, it is a good idea to do posterior capsulotomy with a thorough anterior vitrectomy. The technique could be with forceps, with with the cutter, or with radio frequency endodiathermy, or one can use even the femto laser for that. The size should be 1 to 2 millimeters smaller than your anterior axis. The anterior vitrectomy again is very important, because even if you do PCC and there is no vitreous loss, because the anterior vitreous face is going to be intact, that acts like a scaffold for the PCO to form. So you need to do a thorough anterior vitrectomy whenever you are doing a PCC. Now, IOL implantation again is a very important topic for one to discuss. Is generally more than 1 year of the age, one can go ahead with the IOL implantation. Less than 1 year of the age, there are a lot of studies which have found that the complication rates are much higher, and you do require a lot of other procedures to do later on because of the complications. So it's better to avoid it less than 1 year. If it is a unilateral cataract in less than 1 year, you can give contact lenses for the visual therapy. So in general, IOL can be implanted if the axial length is more than 17 millimeter and corneal diameter is more than 10 millimeter. The choice of IOL will be hydrophobic acrylic lens, which causes less posterior capsular opacification. The perfect would be, and it is a decently biocompatible also. The perfect IOL would be actually a hydrophilic anterior surface and the hydrophobic posterior surface, because hydrophilic material is even more biocompatible than hydrophobic, but the hydrophobic will cause less PCO, but we do not have such IOLs. Multifocal IOL better to avoid in children. Now, IOL power calculation again is a very important consideration to take into account, because the axial length increases rapidly in 6 months, and later on it increases slowly, but it increases almost till 8-9 years of the age. For the and keratometry also rapidly reduces in first 6 months, and then it stabilizes at around 2 to 3 years of the age. So these are the considerations we need to take into account while choosing an IOL, while calculating an IOL. There are different methods which kind of undercorrect, which gives us an idea about undercorrection of the IOL, because the myopia happens later on. The one which I like to follow is the PROST, where it gives you, suggests the undercorrection of 20% between 1 to 2 years of the age, 15% between 2 and 4 years of the age, and 10% between 4 to 8 years of the age. After 8 years of the age, you can put as we are calculating for any adult cataract. Also, you can do, if you don't want to do, is for the correct this thing, intraoperative aphakic refraction and abrometry, and that way you can calculate it. By a lot of studies, they found that the SRK2 and Holaday2 formula work best for children. Now, there could be a lot of complications which can happen with pediatric cataract surgeries, like glaucoma. The incidence is pretty high, 10 to 25%, because these are younger eyes. Sometimes they are microphthalmos. There's a lot of inflammation which happens later on. The visual axis opacity again is a big problem for us to tackle. And as we discussed, less than 6 years, that's the reason why we do PCC with anterior capsulotomy, posterior synechiae formation, and there is a chance of retinal detachment also. I'll just play this small video. So, I can't forward it, right? Okay. So, basically, this video will show how the anterior capsulotomy is done. And the other thing what one needs to do is, after the PCC, either you can keep it in the bag, or the better method is to do the optic capture. You keep your haptics in the bag and put the optic behind through your posterior capsulotomy. That is what one needs to do it to do the optic capture. So optic capture will prevent your visual axis opacification, and also it will stabilize the lens pretty well. This is slightly so this is how one can do the posterior capsulotomy along with the needle, also needle, and like give a nick with the needle and then use your forceps. Or one can do it with the vitrectomy cutter from the anterior approach, or you can put the IOL and then go through the pars plana and do the posterior capsulotomy and anterior vitrectomy. Yes, I'll just show the optic capture thing. So this is how, I'll just show you the photo of optic capture, because my video I cannot forward it. And this is how the optic capture will look. If you can see it, there is a round anterior capsule and a kind of an oval posterior capsule, because the optic is captured behind the posterior capsule. So to summarize, again, the visual rehabilitation is must. So occlusion therapy and amblyopia treatment is very, very important. To summarize, family counseling is important to tell them about the risk, amblyopia and occlusion therapy. Salient features of technique to always remember: less than 1 year, leave it aphakic; more than 1 year, IOL can be considered, and PCC with anterior vitrectomy and optic capture should be done to avoid visual excess opacity. Thank you.
Thank you, Dr. Sheetal. Now, can I invite Dr. Santosh Bhide? He is going to talk on perfect surgery, consistent and reproducible results. Can I request people sitting on the back rows to please come forward?
Yeah, so good morning, everybody. At the outset, I would like to thank Bhalla sir for giving me the opportunity to speak on perfect surgery, consistent and reproducible results. He said you have to talk on something different.
Dr. Santosh Bhide needs no introduction. He is a prolific cataract surgeon from city of Mumbai.
Pune. I'm from
Pune. And is also president of Maharashtra Ophthalmic Society. And we are privileged to have you here, sir.
Thank you, sir. So Dr. Bhalla sir said that you have to talk on something different, not the routine ones like PCR and all that. So he has given me the topic of perfect surgery, consistent and reproducible results. So thank you for the opportunity. See, we all know that the cataract surgery has evolved in last 3 decades because of the advancement in technology and the techniques and availability of high-end machines. And we all know that the cataract surgery is one of the most prevalent surgical procedure in all the medical specialties performed worldwide. More than 20 million surgeries are performed every year. And phacoemulsification is a gold standard surgery with intraocular lens implant in the bag is a standard of care. And we all know that phacoemulsification gives excellent anatomical and functional outcomes. So we have to perform perfect phacoemulsification surgery in all the patients. It is like asking our cricketers to do century in all the matches. So there are 2 aspects. One thing is the perfect technique, and second thing is consistent and reproducible results in challenging situations. For achieving this, preoperative evaluation is the most important key. We have to do thorough slit lamp examination, assess anterior chamber depth, and intraocular pressure has to be checked because sometimes the anterior chamber depth is, if it is very shallow, then we can plan preoperatively. We have to watch for corneal opacities, dense arcus. In patients with dense arcus, there is always a chance of Descemet's detachment, sudden Descemet's detachment. Another important aspect which we often overlook in our busy practice is to look for ocular surface and to rule out dry eyes. We all plan for premium implants, and if the patient is having dry eye or some ocular surface disorder, in spite of giving 6/6 and N6 results, patient will be unhappy. So to avoid such unhappy patients and to give perfect vision and perfect results in our cases, we have to evaluate ocular surface preoperatively. You have to rule out zonular instability. On slit lamp examination, sometimes we miss zonular instability, but if you are suspecting zonular instability, then there is no harm in examining patient in lying down position under the microscope because it's a 3-dimensional structure. Sometimes we feel on slit lamp examination the zonules are okay, but in the OT we find that anterior chamber is so deep, and once we start injecting the viscoelastic, we find that zonules are really weak and there is a lot of zonular instability, and we are not prepared for such case. Topography is a must if we are planning toric implants in cases of pre-existing astigmatism. Detailed examination of retina and doing OCT is a must, especially so if we are doing premium implants. Another important thing is selection of anesthesia. If you are in a private practice, there is always a tendency that I will do under topical 2-minute phaco. There will be no patch, no injection, nothing. But if patient is uncooperative, and if we are trying to operate such patient under topical anesthesia, I am sure that there will be a lot of problems for a surgeon as well as the patient. So it is better that you assess patient whether he will be cooperative and select anesthesia accordingly. And most important is biometry. I think Professor Bhalla has already given a talk on how to do perfect biometry. Intraoperatively, certain tips are you have to avoid blunt keratomes. If you have a big list, if you are working in a government setup or if you are doing a camp, then there is a tendency to reuse keratomes, and those are blunt, and there is a high chance of Descemet's detachment. So avoid blunt keratomes. Proper visualization during surgery is a must, and you should not shy away from using stains to stain the capsule, especially if there is a dense arcus, or if there are some corneal opacities, and if you feel that the illumination is not sufficient to visualize the anterior capsular edge, better to stain. Avoid tight incisions to avoid wound burns, and for corneal endothelial protection, Arshinov's soft shell technique and use of BSS Plus will definitely help you. Capsulorhexis is one of the most important steps in phacoemulsification. If you are doing SICS, then tunnel construction is the most important step. But if you are doing phacoemulsification, then capsulorhexis is the most important step. And integrity of capsulorhexis edge gives strength to capsule to withstand wide fluidics, fluctuations in intraocular pressure and bombardment with nuclear fragments and turbulence of fluid. There are, if you look at the mechanics of capsulorhexis, there are 4 forces which are acting on the capsule during capsulorhexis: the extrinsic force by the surgeon, centrifugal force by the zonules, leakage of viscoelastics from anterior chamber, so there is an egress of fluid, and there is a posterior vitreous thrust. So you have to balance in such a way that there will be a proper capsulorhexis. Capsulorhexis has to be of adequate size. The capsule has to be stained. Anterior chamber has to be maintained throughout the surgery. The depth should be maintained. If there is a need, you can refill the anterior chamber with viscoelastic and flatten the anterior chamber. It is better to use high molecular weight viscoelastics like Helon while performing capsulorhexis. In case of intumescent cataracts, when there is egress of milky fluid, you have to aspirate the interlenticular fluid. So we all know about the ideal capsulorhexis, which is necessary. The next step is nucleus management. During nucleus management, endothelial protection is most important. So proper selection of OVD and irrigating fluid is a must. There are various techniques: 4-quadrant, stop and chop, direct chop. Whatever works best in your hands, do it. It is a tendency that we go to conferences and see stalwarts operating and talking about direct chop, this chop, choo-choo chop and everything. But whatever works best in your hands, do it. I think stop and chop is the best technique which everybody can do. I like to take a small conjunctival flap before, so as to avoid ballooning of conjunctiva during phacoemulsification. I think this tip is given by K.K. Mehta sir in the initial stages, and you can also go posteriorly. Another thing is that you have to aspirate all the muck and the viscoelastic before starting phaco to avoid wound burns. Take a deep trench, rotate it. You can crack it into 2 halves. The tip is that look that the posterior plate also should be properly separated, especially in leathery cataracts. Now here the posterior plate is separated, and then removing all the other fragments is quite easy. So because of paucity of time, I'm just forwarding these videos. So to summarize, proper preoperative assessment and planning of surgery is a must for achieving perfect results. Avoid repeated entry into the anterior chamber. Avoid tight wounds so that there are no wound burns. Avoid excessive phaco power. Use of a OZIL technology or torsional phacoemulsification technology definitely helps us. Proper selection and judicious use of viscoelastic devices is a must in the back phaco. There is a concept of 1 minute phaco by Dr. Abhay Vasavda, which is very useful. And most important thing is that you have to maintain the anterior chamber with viscoelastic devices. We have to achieve speedy recovery of the patient and not speedy surgery. There are some surgeons say that I finish surgery in 2 minutes, I perform 100 surgeries in a day. So we are not Formula One drivers. Safety is a first. So you have to maintain the safety of the patient and kill your ego. If need be, you can tell help of your VR colleagues. I would like to thank Dr. Bhalla sir again for giving me opportunity to talk on this talk. Thank you, sir.
Thank you, Dr. Santosh. Very rightly said, speedy recovery is more important than speedy surgery, because for us, that patient may be one of the many cases on the list, but for the patient, these are his only two eyes. So we have to take it, really give that precious time to the patient. Yeah. So now we have Dr. Anand Parthasarthi, and he is going to talk on phaco in post-keratorefractive surgery eyes. Dr. Anand
Can
Parthasarthi
you load
comes
my
from...
presentation?
Yeah. While his presentation is getting ready, Dr. Santosh sir, do you recommend OCT evaluation as a routine in all your cataract surgery cases? OCT evaluation and dry eye evaluation? Exactly. I think with the premium, it's a must, I think, because it's not only important to have good. Yes, I think it's very important where the patient's visual status is not matching with the grade of the cataract, or when we are putting premium IOLs, and particularly you may find that the patient may be having diabetic macular edema is there, which may worsen post cataract surgery. I think it makes sense to do OCT evaluation in these era. It also helps us to have a good baseline evaluation. The record is there that the patient's visual recovery, if it is less than optimal after the surgery, it is not because of any surgical complication. It is because of the edema, diabetic macular edema, which has worsened. Yeah, Dr. Anand, it's
Yeah, I'm ready. I see my presentation here on the laptop.
exactly. Yeah.
All right, thank you so much for allowing me to be a part of the session. I decided the most important part about the post-refractive eyes and corneal procedures is actually getting the K. No financial disclosure, but it would be nice to have some. I guess getting accurate K is like achieving nirvana. Once you get that and you're happy with the results, you're almost sure that you would get majority of the part right. So I'll start with this one of my patients. They're in the business of government contracts, diagnosed to have at another hospital, an history of RK done for a myopia of -8 in both eyes. Her children are doctors. Her son is a clinical trial specialist. He's done intensive research on the types of IOL and me. And he's read all my papers published. He has a discussion with me on my PCR rates, number of premium IOL surgeries done. And son also discusses the average post-operative results, including the confidence intervals. Now, the doctor then decides that she wants to come in and observe surgery, and the patient's preparation is a standard pre-op preparation, which included eye drops, which is antibiotics and NSAIDs. My pre-operative preparation include prayers to all the 33 million gods that we have. Luckily for them and me, the surgery went off perfectly. And this is the pre-op. You can make out the RK cuts quite deep, and we planned the incision for the cataract based on that. Luckily, we were lucky with the topography that we could actually get a reasonably regular astigmatism, and we planned for a surgery based on that. Post-op, the results were actually quite good. You can make out the cuts do come a bit into the visual axis, so this is important when you're planning the positioning of the IOL. At the end of the day, the hospital were happy with the income, and I was happy with the outcome. And when you do a PubMed search at about 5:30 today, I found that there is a very significant amount of published articles, and this is something that's probably going to go up. Now, when you're getting the IOL power, especially for these set of eyes which are post-refractive surgery, keratoconus, ectasia, keratoplasty, or post-RK, it's important how well we actually do in these situations. How well we do in normal eyes, I think most of us would be between 80-90% of about 0.5 of the target, and with the present formulas, most of them now available online, it's actually quite good. But in patients with excimer surgery, and there's a report by AAO, how accurate are we? And there are multiple sources of errors. One is, of course, the axial length, the keratometry, and the effective lens position. These are important factors in each eye, especially in these eyes which are high myope, with probably some changes in the zonular positions, they tend to vary. When you have a patient with previous RK, PRK, or RK, you need to have basically look at the ablation profile. So topography especially is important to check what is the way the ablation is being done. There are, of course, multiple biometers, and all of them have different amounts of measurement in the central part, and they tend to overestimate because of this central flattening. So definitely look for small optical zones or for decenter ablations. There is, of course, a change in the anterior and posterior corneal curvature. And usually the standard refractive index, which is about 1.3, is used for this assumed keratometry. So this changes, hence your keratometry amounts will also change. There is, of course, the second part, especially in high myopes, where we know that the zonules and the bags tend to be not within the normal limits. That's why the effective lens position changes. So most of these IOL prediction formulas use the keratometry and the axial length to estimate the effective lens position, which is basically an estimate, hence not very accurate. So you need to understand that you're not aiming for a 100% result. If you get about 80% within about a diopter, not 0.5 for normalized, but about a diopter, you're pretty good. Now, when you have multiple ways to measure K, which one do you actually choose? Because there is a very, very wide variety. Manual keratometry, if you're actually good at it, for normalized, it works well. For slightly irregularized, takes a bit of practice. But since we were trained on this, I know that they tend to give fairly good results. Auto K, not a bad start is what I would say. If you want me to give marks, probably about 80 out of 100. But the other present IOL masters or the lens stars where you have multiple points of measurement is actually a good idea. So corneal imaging, probably the best because the number of data points goes up dramatically from about 10,000 to about 25,000 depending on the type of machine you use. You have Placido, Scheimpflug, OCT based, which are true case, and now in a hybrid in terms of eye trace. And if you're in a private practice and you want to use the machine for multiple uses for treatments, usually the first two would suffice quite dramatically. Now there is something called the EKR in Pentacam, which measures the central keratometry across the range, which is normal, LASIK, and RK. So if you can see, the average over a 4 millimeter zone for a normal patient is between 41 to 44, which is actually quite good. But for a LASIK and an RK, the spread is actually huge, especially if you look at RK, it varies from sometimes 32 to about 45. So what is the zone that you need to take? Now, there has been some studies based on what would be the ideal zone, and usually a 4.5 may not be the exact. You may need to take slightly smaller zones as the point of reference. So I prefer to take between 3.5 to 4. Now, corneal topography, probably a more reliable tool because you have a larger diameter of measurements. You have the EKR in Pentacam, you have SIMCase, you have TKR, total corneal power, and IOL masters, and there's something called TMP in OpScan. So both, all of them I have used, all of them I feel give fairly consistent results. You can then plug these keratometry in on online calculators, and we are lucky to live in a generation where you have access to all this at no cost, and these are free. You can get them, and I've used all of them. I find them to be actually quite accurate, not much variation in the websites as well. This is just an example of how you would actually look at it. Now, if you have the IOL power calculation, it gives you basically with no prior data, or you have some prior data, it gives you an average with a max and minimum. So that part is your clinical decision. How much do you want to aim for? Which formula do you believe in? Our experience says that if you have a combination of OCT measurements, a Pentacam or a Scheimpflug based keratometry, you would be almost about 90% in terms of being on the right side of the power. Now, there are, of course, multiple studies also published on the calculation power, selecting the data. And I think, as I said, 80% within 0.5, 90% within a diopter, you're quite good. The true K formula was something that has come in over the last 10 years. And I find that true K, especially for training the optometrist, is actually a very, very good idea. Post RK corneas, as I said, slight change doesn't fit into the normal parameters, but the results with these IOL power online calculators has been actually quite good. There is one subset which we have started seeing a lot more of keratoconus patients, which can be basically eccentric cones or central cones, or at least a regular part, have some part of it having a regular astigmatism. The points to keep in mind is the visual axis, the steep keratometry, and the position of the cone. Remember that mild may still be happy with wearing glasses. Toric IOLs, if you have a regular part of the irregular astigmatism, you can still use. And if they are already wearing RJPs, maybe a good idea not to wear to use toric IOLs. Aberrations is something that we have done work on. I won't touch upon it, but broadly remember that they would have a bit of glare and halos even after surgery. And if you have grades of keratoconus, from good, the tolerability in terms of repeatability and for all the imaging is good for mild to moderate. For the severe cases,
Dr. Anand, can you summarize?
Last tends to be worse. In terms of the generation formulas, the fourth generation formula is probably the best. So in terms of modern cataract surgery, the talk about AI is probably more the person, which is more important. The man behind the machine is a lot more important. So in conclusion, you need to counsel the patients for suboptimal outcomes, be aware of the sources of the error, use online calculators, and remember that there are some eyes which may not fit into your 100% result. Thank you so much. Acknowledgement for a couple of people who helped me with the slides. Thank you so much.
Thank you, Dr. Anand. Now, can I invite Dr. Nivian? Dr. Nivian is going to cover a very important topic. After having done the correct, perfect surgery, perfect IOL calculation formulas, now which is the IOL which you would like to choose? So choosing the right IOL, monofocal versus multi or trifocal versus EDOF lenses. Dr. Nivian.
Thank you, sir. I'm just waiting for the presentation to come up.
Dr. Piyush, what do you normally do in these post-keratorefractive surgery eyes? What is the keratometry? Which instrument do you rely on? EKR 4.5 on Pentacam or IOL Master 700 Total K, and which formula?
The best combination which I am using in my practice is either a combination of EKR at 4.5 millimeter with a Holiday 2, or using a Lenstar 700, where we use the Barrett True K with the TK. And that is the, I would say, the gold standard these days. And I also have an entry on, as I was showing, the Oculix, in that the software, which is a wavefront guided, also gives a good measurement. So mostly depending upon the case scenario, I try to take an average out of various things, because none, I would say, would be 100% promising one. So especially in the RK ones, we generally try to aim towards the myopia, the maximum IOL power we get out of the various calculations we do. And at times, with if you don't have an access to multiple instruments, I believe if you have a Pentacam and you can go with the central K values, even that works very well.
Right. Okay. So Dr. Nivian,
Yes,
please.
So respected teachers, senior ophthalmologists, my dear friends. So I'm going to talk about choosing the right IOL between monofocal, multifocal, EDOF, and trifocal. Can we have the slides up there? Yeah. So I do not have any financial interest, because we have so many types of IOLs and so many companies that are involved in this. But there are certain drivers of good outcomes after cataract surgery. The first key most important is safety and efficacy, because that is the most important. And as long as the patients are happy, definitely everything goes well. Then the efficiency, I think the previous speakers have spoken about how to get a perfect biometry to do the perfect surgery. So all of us are trained to do that. Then nowadays we all know that cataract surgery is not only giving just 6/6 distance vision, but patient wants 6/6 distance visions. They want N6 near vision. They want intermediate vision. They want good contrast and no glare and halos. So all these terminologies are being known by the patients also, thanks to the internet. So, and we are also achieving target immetropia. I think initial days it was about 6/6, but no longer it is just 6/6. All these things put together is only target immetropia. So how do we choose an IOL? Like there are 2 points of view, one from the surgeon's point of view and one from the patient's point of view. So we are always focused about the lens material. Yes, hydrophilic, we know the advantages and the disadvantages comparing between the hydrophilic, the hydrophobic, and the surface coated lenses. And the various designs we have, the C-loop, we have the plate haptic lenses, the four loop haptic designs, and then the various cost of all these lenses. Procedure wise, I think now the phaco has become a gold standard, and the 2.8 incision or the 1.8 incision. So there is a quick and fast recovery because the next day patient wants to see all these things, or sometimes in some hospitals, I know the same day their expectation is to read all the letters and they want to get the other eye done the next day. And we are also worried about the PCO and the spectacle independence. So nowadays, choosing the right IOL requires a complex and objective assessment of various factors. One, we should know about the optical properties of all these lenses and not just go by what is driven by the market, and the visual quality. So there are two key important things here is one is the quantity of the vision and one is the quality of the visions. There is also a new classification according to the patient side. One of the I've just classified this on my own, like the social causes, like how motivated is the patient in getting this IOL. So that is a very important thing. And most of the patients we know come saying that my neighbor has got this or my relative has got this. So they also know about what are the advantages of those things and how happy he feels, and that puts us under pressure. Then the other things like the lifestyle of the patient, what are his do's and don'ts. That is why customization is the key word here, and it is not like one size fits all. So customization is the key for choosing the right IOL, I would stress here, because different models are there, different companies are there, and the other factors as far as our country is concerned is the costs also. So what I meant is that extra chair time is very important. I think all the speakers must have told about this. Just to know when they say reading, hereafter reading what used to be only the books is no longer reading. So if they're reading, then they need to have good near vision. So you should plan that kind of an IOL which gives you a good ad power. But if they're going to read in tablets or their reading is going to be in laptops, then you should think of different group of lenses like the EDOF lenses, which are actually better when they give a range of vision. And then what kind of activities do they play? Are they sports driven persons? Because unless we ask, we will not be able to know. We can't assume things nowadays with the patients. So spending those time and asking them what are the extracurricular activities, is it just reading or they do outside activities like golf or driving. So all these things are very, very important. We tell them, but most of the times in our practice, because of a busy practice, we did not ask these questions. And later on when the patient says, doctor, I'm doing this, I'm not able to focus when I play badminton. So that is when we are hit actually. So we have all the different types of IOL options. So we all know that monofocal is only going to cover the distance vision, and multifocals are very good in covering the distance vision and the near vision. So always there used to be this fine line between trifocals and EDOF when I started off. So I keep it very simple. So trifocals have all the three zones. So they cover distance, intermediate and near. So EDOF is very good for distance and intermediate because that is where the range of vision comes. But there's a slight compromise of the near vision. But most of the EDOF lenses people say we usually give a myopic shift so that bilaterally they are happy with the vision. So as I said, between multifocals and trifocals and how the different types of lenses work. So we did our own study just to explain in a nutshell to first here. So we chose four different types of IOL. So monofocal IOL, multifocal IOL, EDOF lens and a trifocal lens. So we chose four different IOLs and subjected 30 patients in our study to understand, even though we know the properties, in our hospital we have this, anytime a new lens is introduced, we always take it up a challenge that we do a study on those lenses about the patient for us to understand as doctors how the particular lens work. Is it giving the same results as what is told by the company? Only then that it increases our confidence, and then once we are confident, we know when is the right patient that deserves the IOL. So the multifocal, we chose the accretive IOL. As you can see, most of these multifocal lenses have lots of rings and they're closely packed. And because of the sharp edges is why they had more glare and halos. And then came the group of trifocal lenses where you have both the plate haptic design and the loop design. So basically, because of the spacing of the rings, it gives you all the three ranges of the vision, and they have this apodization, that is, those sharp edges have been rounded off, so the internal reflection of the light that happens in these multifocals are lesser, and because of that, the loss of light energy is lesser in these trifocals. That is why you're getting all three ranges of vision with lesser glare and halos. It will never say that no glare, because any lens that has rings will have some amount of glare and halos. It is just that we use the word lesser glare and halos as compared to multifocals. And this was a study which we did 2 years back. So that time we were doing it with InFocus IOL. Nowadays, I think all the companies have come with various different types of EDOF lenses, but they all work on the basic principle of inducing positive spherical aberration on the surface of the lenses that elongates the range of vision. So here again, at that time we had this InFocus lens which has got that central zone which helps in giving the near vision add. So this is the newer, the Rainer extended monovision lenses. As you said, these EDOF lenses, you don't have those rings. It works on the basic principle of the inducing positive spherical aberration on the anterior surface of the lenses. And most of these lenses are all fully preloaded lenses. So they also call it as a no-touch technique, where you don't have to remove the lens from the cartridge and place it inside. And you see here, you can't see the rings. So going on to the results, ours was a 1-year follow-up period about comparing all these lenses. So the exclusion criteria was the same for any of the trifocal lenses, like any retinal pathology, glaucoma pathologies were not included in this particular study. But what I like to emphasize is the EDOF lenses are very forgiving lenses. So I would say that is more like a glorified monofocal lenses, where even if you have a retina pathology or a glaucoma pathology, there is no drop in any contrast or anything when you use the EDOF lenses. So in our study, if you can see, as far as the distant visual acuity is concerned, all the lenses gave good visual acuity. So all 4 lenses are good for distance vision. But when it comes to the defocus curve, you can see that unifocals work only for distance, and the orange line has 2 peaks. The multifocals always 2 peaks, and you have an intermittent gray area. And then the trifocal, you can see the gray line which has 3 peaks here, and the EDOF lenses which has a range of vision. So as far as the contrast, yes, it is very evident that monofocals and EDOF lenses have the best contrast sensitivity, as there is no rings. It is almost as normal as what our normal lens is. And multifocals was the least, and trifocals were far better because of the reasons as I told you, because of the sizing and the shaping of the rings that are there in the lenses. So the spectacle independency was the maximum for trifocal lenses and EDOF lenses as compared to the multifocals and monofocals. So in conclusion, it is good to know about all the ranges of lenses, and actually we should titrate it to what the patient wants. So what the patient's needs are. So then we have to explain it to the patient how it's going to work. And also in any of these lenses, we always tell that it is only 98% chance. There is always this 2% or 1% chance that you might be requiring glasses for doing your work. And that has actually helped us a long way. So considering the surgeon's experience with IOL technology would be better than just going with the manufacturer's marketing strategies. So no single multifocal IOL or EDOF lens will suit all patients' needs. So we need to have an holistic approach in this particular thing. So once again, like to thank AOS and BHALLA sir for giving me this wonderful opportunity. Thank you, sir.
Thank you, Nivan. That was a very illustrative talk. Dr. K.K. Mehta is here, sir. Can we have your pearls of wisdom on if a ophthalmologist comes to you for a cataract surgery, sir, with the precision, with the depth of focus, stereopsis, everything which are very paramount of great paramount importance to him. What is the type of lens will you like to implant in an ophthalmologist who has a lot of surgery also to do? Give mic, please. Mic.
Theoretically, the correct answer would be a lens which has an extended range of focus. In practice, the best lens is a trifocal. Among the trifocals, the only question you have to decide is to which is the one which will give him the minimum glare and problem. Now, an ophthalmologist does require to be able to not only see his screen, see his thing, at the same time see the intermediate range. So, I mean, in every way, I think trifocal is the way to go, and that's what I recommend to everybody. We have had surgeons who have, we have had a good ophthalmic surgeon, a friend of mine, who cribbed a lot and said, I don't want this, I don't want that, and I put in an extended lens for him. After a period of 15 days, he comes and says, Keki, I can't manage with this thing. I can't see. I have to wear reading glasses again. My life has again got spoiled. Can you change the lens? So I had to remove the lens and put in another lens. So I mean, that remains the point of view that I still feel that giving 3 ranges of vision is far better than giving 1 irrespective. The only ones who are happy with a single range of vision are those who are business people who sit on a table, or those who want to play golf, for example. They are happy with it. But all working people like you and me require trifocals.
Thank you, sir. Now, the next speaker is Dr. Parul Sharma, and she is going to talk on optimizing toric IOL accuracy.
Can I have the slides, please? Thank you, Dr. Bhalla. So I'm going to talk upon how to refining the surgical technique and how to get the best out of your toric practice. We've had some very good talks. So I'm going to skip what has been covered and just touch on the few points which we will be divided between these 3 categories of how do we get the best out of pre-operative, intraoperative, and how do we manage post-operative. So it all starts with the patient workup. And of course, all of you know how to do a standard pre-cataract workup. But in toric lenses, what becomes important is, as earlier speakers have defined, is to look for any ocular surface disease or dry eye. And I'll show you how it can affect your biometry in the subsequent slides. If you do not have an optical biometer, because everybody is in a different stage of practice, you can very well use your ultrasonic A scan, but please use the immersion one so that you do not have inverted contact indentation errors of your A scans axial length. If you have an imaging system, great, plan and your image simulation chart prior. And to get good results in toric, you have to incorporate corneal tomography in your preoperative workup. So that's important. And of course, like any other cataract surgery, you may not charge your patient, but just screen your maculas for all of them, and you'll be surprised by how many fine ERMs and other stuff you put. Toric lenses per se is not a contraindication with posterior segment pathologies. You can even do with them with all kinds, because it at least corrects and takes off the majority of your bulk of your the astigmatism. But initially when you're starting, you may want to avoid that. Corneal topography is important to rule out irregular astigmatism because that affects your ultimate refractive results. Small astigmatism, especially with the rule 0.5 less, will get compensated in your biometry when you calculate the chart. If you're a beginner, rule out small pupils because then you don't know where your marks are, and of course, capsular instability. So there are many, many areas, as you've heard so far the speakers say, on how you can improve your biometry. Basically, it's putting more time and putting more effort. And as I said, that switch from A-scan, your regular ones, to the immersion technique. Now, coming to optical biometry, what we all forget is the calibration. You may be best, you may be spending as much time, but if you're not doing the weekly calibrations, you may be off in your certain reading. So make it a point to ask your optometrist whether he's done nullifications and calligraphy. Now, how many of us look at the head tilt when we are doing measurements on our optical biometry? And this is a very important thing because there are many studies which have documented that if there is a slight tilt, your axis mark could be off in your biometry by almost 10 to 20 degree. So here is a biometry where, to demonstrate, we have taken the first picture is where the patient has a tilt, and you can see that the toric marking is on 72, and the other one where we have put the head straight comes at 82 degree. So please make sure that there is no head tilt. Similarly, when you're doing biometries, when you're taking the measurement, even if it's for the axis or the pupil barycenter or kerato, there will be some outliers. So you manually need to remove those outliers so that maximum of your readings come within the standard deviation acceptable. So this is all how you keep removing, you keep refining, and you get the most accurate results on each parameter. So when you're doing the post-refractive ones, toric IOLs, it's important to know your angle kappas. Angle alpha is only in eye trace, but at least most of your optical biometries will give you pupil barycenter. So as Dr. Bhalla had spoken earlier, we used to get confused which eye formula for which length, but now for all practical purposes, there is a Barrett suite available online, and that's a go-to formula for most people. And these are the top 2-3 formulas, so that's a no-brainer here. Now, again, reinstating, if you want to refine your toric IOL practices, do look at the surface, do treat dry eye before the surgery, because you see how here there is a difference when we have treated the patient before and after the dry eye treatment. There's a complete one diopter spherical, and it will affect your visual outcome. Similarly, a patient before and after the ocular surface treatment, and you can see both the spherical and the axis component have got changed. Now, that's the acquisition part. Now, small things which you need to see pre. Now, in your toric IOL calculation, the main thing is the steep axis. So whenever your axis is, you're doing, take an average of, two instruments at least, and topography or tomography is the best one to access your steep axis. So that is where your focus should be. In calculation, what affects is your SIA and your A constants. You can, most of us are doing 2.2, so you can safely go take a 0.2 as a centroid, but if you're doing larger incisions, then you need to calculate it. Most of the company guys will help you to take out your SIAs and A constant. You need to just give them 50 of your data, pre and post. Otherwise, you can go online and use these kind of tools as well. So this is reference sheet, and as we've heard that the mistakes happen when either the acquisition is not correct or your reference sheet is not correct and you've not placed. So be careful when you're doing that. Posterior corneal astigmatism will affect your toric calculations, and this is an example to show you that when the patient, I mean, if you look at your, with the rule, here the patient has a 0.86 and a 0.93, but because of the posterior corneal compensation, this patient has a non-toric model, vis-a-vis if it's a same kind of astigmatism, but if it is against the rule, you almost need a T3 kind of a model. So not for us to do anything, the machines calculate and tell you as much, but it's important to be aware that this is how the astigmatism and the models will vary. Similarly, we all get perplexed when we have a small amount of a 0.5, 0.75, whether to do a toric or not. And this is where you can use your toric planners on your optical biometry. And here, initially, on a temporal axis, it's saying to use a T2 model, but when I switch and make the incision on the steep axis, I've come onto a non-toric model. So this is also, again, how you can refine and go onto your toric planners and decide what kind of lens to be used. So again, another example where after modifying the incisions here, the results become better and the model also changes. So go on to the toric planner, that helps you. Similarly, in post-refractive patients, you need to be sure that the optom has picked up the right formula. So there's a drop-down. Make sure that the Barrett True K formula has been used. And take help of Pentacam. Dr. Piyush and earlier speakers have already spoken that they focus on the 4.5 millimeter zone to pick up your keratometry. So I would not be repeating that. Few things in your marking, I would just say that either whether you're doing a slit lamp one or whether you're doing the gas bubble one, you just have to make sure that the cornea is dry. So most of the time it will run off if your cornea is not dry and you'll get a smudged thing. So that's the only thing which I need
Dr.
to say to
Parul, can you
refine.
summarize
Yeah,
this?
I'll do that. And in per operative, as they said that most of the things have been covered, the only thing I would say is that when you're putting your lens, just make sure that the last position is 20 degrees before your actual marking, so that by the time you finished your visco and hydroaspiration, you align your axis onto the corneal incision by rotating it clockwise. And post-operative, there's a complete talk, so I'll skip this part. There's online calculator to do that. So I don't think I need to summarize also. Thank you so much.
Thank you. I think it was a very exhaustive topic and you had to rush through because of paucity of time, but thank you, you made your point. Now we have Dr. Sachin Maholi. Dr. Sachin Maholi is a renowned vitreoretinal surgeon from Belgaum, Karnataka, and he's going to tell us about cataract surgery in post-retinal surgery eyes.
A very good morning to everyone. I thank Dr. Jatinder for giving me an opportunity here. So these are the different cases and the special case scenarios and where you have to do a cataract in post-retinal surgeries, and we'll be discussing the problems what we encounter preoperatively, intraoperatively, and postoperatively. Preoperatively, you need to assess the vision properly because we need to prognosticate them. You need to look into the refraction, especially in oil-filled eye. They will have a hyperopic shift in most of the cases. Fundus assessment is a challenge because of the PC plaque, dense cataract. High myopes, again, the peripheral visualization is a challenge in such cases. But we'll come to biometry a little later. Silicone oil in the anterior chamber also will, cause a problem to assess the posterior segment. Corneal scars in trauma cases is also a challenge for such cases. In biometry, especially in silicone filled eyes, it's always better to use an optical biometry if the cataract is not very dense, and you will be able to calculate, because most of these machines have a silicone oil filled eye mode. You can select whether it's a 1000 centistroke or a 5000 centistroke oil, and then based on that you can look into the lens power. Especially in cases with scleral buckling, patient who have undergone scleral buckling, you should know that there is an elongation of the eyeball because of the indentation, usually up to 2 diopters in the myopic side. Corneal scar related astigmatism, especially in cases who have undergone a combined trauma with the retinal surgery, could be a challenge for the IOL power calculation. In these special cases, what you should follow is always rely on a preoperative refraction of the patient. If you have a document of, a patient is with you before the surgery, then you should record everything before the retinal surgery, so that it will give an idea whether the patient was emetropic, high myope, or a hyperopic. So that will give a lot of idea, and always check the other eye biometry before you inject a lens in these cases, because it does give a lot of clue, especially in cases of corneal scars when your K readings are not very reliable. Refractive surprises in most of the cases are very common, and you should be prepared for those issues. So what are the special problems intraoperatively? These are hard leathery cataracts most of the time, especially silicone oil induced cataracts. Small pupil is again a challenge. There could be a posterior synechiae for which you need to be prepared. Anterior chamber fluctuation, AC depth fluctuation. So you need to play around the flow of the fluid in the anterior chamber and customize it according to the patient. PC plaques are common because lens touch and other issues need to be looked into. So intraoperatively, what would you manage is small pupils, either use hooks or Malignant rings, wherein you can dilate them properly. Runaway excess because of the lens hydration also is very common. So you should be prepared for that. Leathery cataracts, it is difficulty during chopping and emulsifying. Weak zonules, especially in buccal cases and post-vitrectomy, are very common. So you should play around the fluidics accordingly. Lens touch causing PC dehiscence and PC plaques are very common. So document a lens touch whenever it is there preoperatively. So hypertony related issues are also there in certain cases when you post oil removal cases, which will cause a problem with the getting a perfect tunnel. Use a lot of viscoelastic AC depth for fluctuation, especially in the high myope once the oil is removed. Emulsified oil in the anterior chamber is a bigger challenge. Before starting the surgery, you will not be able to assess the grade of cataract, so you need to do a thorough wash of the anterior chamber. So during this process, the challenges what you can face is the fluid can gush behind through the zonules, and it can cause sudden shallowing of the anterior chamber. So you need to be prepared to remove the oil with the pars plana route before you proceed with the phacoemulsifications. Rexis related problem, as I said earlier, intraoperatively there will be a very poor glow, and if there's a mature cataract, you should be prepared for the runaway rexis. You keep all your instruments, forceps, and other things ready. Anterocapsular fibrosis is very common in post silicone oil filled eye because the oil causes a lot of fibrosis of the capsule. Use scissors, forceps, whatever is required. Stain the capsule whenever it is required. This is a small video showing a case wherein it was a mature cataract, totally hydrated cataract, in which phaco was planned with the silicone oil removal. The capsule was stained. The lens was very intumescent, though it was not very hard. It was a very soft cataract. So most of these cases will have a PC, plaque, very thick. So chances of rent in such cases are very rare, unless you can see this typical Argentina flag, which with just a nick, you could see that it's totally. So the wash was done. The lens nucleus was very soft. A phaco probe was used to aspirate all the lenses, all the lens matter, and the IOL was inserted in the bag. And later on, the rexis was completed using the scissors. So you can see that PC plaque, which is usually induced by a silicone oil. Not necessary that this patient would have had a lens touch, but without a lens touch also, these plaques are pretty common. So handling these plaques are challenging because intraoperatively either you have to do a primary posterior capsular opening with your needle or with the cutter, or you can do a capsulotomy later on in the postoperative period. Because unless this is removed, whatever retina surgery has been done or whatever it is, the vision won't improve to a expected. I'm unable to forward the video. So I just wanted to show how a PC plaque is removed. I think I'll just skip because we are running short of time.
Sachin, I think
so
you can just summarize
yeah,
because we
I'll
have
just sum
the
it up.
last topic.
Yeah, I'll just sum it up.
Thank you.
Handling the nucleus, one important thing which I wanted to make a mention is there is something called infusion deviation syndrome, which you should be aware. If there's a misdirection of the fluid to the posterior chamber, iris prolapse and sudden AC, shallowing is common. Managing PC plaques, as already discussed. Postoperatively, these eyes are prone for excessive inflammation, so you need to be prepared with all the problems related to inflammation. Use more steroids. These are the take-home messages. Thank you very much for your patience.
Thank you, Sachin. Now I'll invite the last speaker, Dr. Vanashri Nair. She is going to talk on tackling refractive surprises post-cataract surgery. I'll request Dr. Vanashri to just stick to the time because the other session is going to start, and I apologize to the next session for just overshooting by few minutes.
Can you start?
Over here it becomes cascading.
Good morning, everyone. First of all, thank you for including me in this session, Dr. Bhalla, sir. So I'm going to speak on refractive surprise after cataract surgery. We heard a lot of talks in the morning today from all the esteemed speakers about how we can achieve a perfect result, what all steps to take, and how to go ahead and give that perfect result to the patient. We know this is an old statistics, 50 to 70% patients achieve within 0.5 diopters and 79 to 94% patients achieve within 1 diopter. I think now it has reached to 90% where we are meeting the targets of getting a perfect refractive outcome for the patient. So when we know that there is a refractive surprise that comes in where the patient is dissatisfied and the spectacle independence that we promised to the patient has not been achieved. So where do we draw the line? Where can we get the best results? So we heard that, how we can achieve it. So we need to have, understanding of the patient expectations, having the chair time, finding out what the patient requires, doing a good optical biometry, and the perfect surgery, and of course the careful IOL selection. So where we can go wrong is again the improper history, improper counseling, improper calculations, unmatched expectations. And if we have missed the history of refractive surgery in the preoperative testing, then we can land up with a hyperopic surprise. So I'll just rush to the initial part, which has already been covered. So determining the, now we know that, okay, we are here with a refractive surprise. We have not come up with the result that the patient expected. So now what? So first of all, we again need to give some chair time, understand, wait and see how is the refraction settling, what is the patient's expectation now, observe and see if he is amenable to a little bit of refractive error, then we can observe and get away with it. But if not, then what? If it is a large refractive error or if the patient is unhappy, then we need to trace our path back. So if it is your own patient, then you go and check your preoperative data, the IOL power calculations that you have done. Make sure that the lens was not by mistake, some other patient's lens was not put in this patient. And on the slit lamp, please rule out capsular block syndrome, because here you can have a myopic surprise where a small YAC capsulotomy itself might solve the issue of the myopic shift. Now, if you have used a monofocal IOL and the patient has come to you within 2 to 4 weeks after the surgery and there is a refractive surprise and the patient is not happy, the first choice would be to go for an IOL exchange. Because here the capsular adhesions have not yet come in and it would be easier to replace the IOL instead of going for the other options. But if the patient has come after say 4 weeks or 2 to 3 months of surgery, then the capsular adhesions have already started. So the better option would be to go for a piggyback lens, and that is if it is a large refractive error. And if it is a small error, then you can think of a cornea refractive procedures like PRK or LASIK after 3 months. Multifocals, again, it is better if the patient is not happy or because of glare and halos, then you may have to replace it with a monofocal. But if it is about the refractive outcome, then it is better to go for an IOL exchange. Piggyback can be tried, but not a really good option. And if the patient has come many months after the surgery, then it would be better to go for a piggyback lens, but we'll have to really rule out the way the refraction may turn out in the end. So where you can try a piggyback lens, the ideal candidate would be a patient where the primary IOL is well settled in the intact capsular bag. There is a normal or a deep anterior chamber. The patient does not have glaucoma or pigment dispersion. The endothelial cell counts are normal. If there has been a hyperopic error, then the piggyback IOL will give you a good result. And also, if there is higher order aberrations are significant, then and you're not opting for LASIK or PRK, then piggyback is a good option. So this is a simple calculation that you can use for the piggyback lenses. Not going into the details, there is a factor which can be multiplied to get the calculation of power. Also, ray trace by Rayner is another system that can be used for the Sulcoflex design IOL by Rayner. Now, this is a piggyback lens which has been developed to give you a sulcus placement as a secondary piggyback IOL. It is a single piece hydrophilic acrylic lens with an undulating haptics. If you see the design of the haptic, it has got undulations. And the posterior haptic has an angulation of 10 degrees. It is a convex concave design so that it does not touch the primary IOL which is sitting in the bag. So there is no inter-lens opacification that can occur. And the optic diameter is 6.5 millimeters and the overall length is 14 millimeters. This optical diameter of 6.5 actually prevents optic capture by the pupil once you dilate in the post-operative period, which is one of the problems that can happen with piggyback IOLs. So coming to toric IOLs, we know that we need to have the precision surgery and the placement, and ma'am had so nicely covered the way we can give a good placement of the toric IOL. But if we know that there is a problem in the post-operative period, we are not having the refractive outcome that we expected, then some of the errors that could have happened are the measurement errors, the incorrect markings of the reference points on the cornea, incorrect placement, or taking into account the posterior corneal astigmatism, dry eyes, and other things. So how do we go back to this? Now, we need to trace back what went wrong. So was the IOL placed correctly? Was there an IOL power calculation mistake? So the technique here that you can use is the simple one is the slit lamp technique, where you dilate the patient and find out the axis where the IOL is lying at present. Then you go back, use astigmatismfix.com, and on that, you can feed in the data as to what is the refractive error that we have now, what was the axis at which the IOL is placed right now, and it will give you a calculation that whether rotating the IOL by 10 or 15 degrees will reduce the refractive error to the minimum. Now, if the rotation of the IOL gives a good result, then you can go in and dial the IOL. If it is not giving you a good result, then you need to go and exchange the IOL or use the piggyback IOL option. Now, if it is a small error and you can get away with LASIK or PRK, where both the magnitude and axis can be solved. So just to summarize, if the error is small, there is no corneal pathology, there are no glares, hollows, or higher order aberrations, then you can go for keratorefractive procedures like LASIK or PRK. And if the error is more than 2 diopters, you know where the source of error has come from, and the patient has come early, you can go for IOL exchange. Torics, you can go for IOL rotation. And if it is a late presentation, then you can think about the piggyback IOLs. Thank you.
Thank you, Dr. Vanashri. I think due to paucity of time, we'll not have any discussion or any questions. So I'll hand over the podium to the next session people. Yeah. Can we have a group photographs?